Good morning, good afternoon, and good evening to everybody. We'll start the session shortly. Let's just wait for a few people to come in case they're having technical difficulties. Can I have the next slide, please? Yeah? So hello, everybody, and welcome again. We'll now start today's proceedings. My name is Kabir Sheikh. I'm a policy advisor at the Alliance for Health Policy and Systems Research. It's my pleasure to welcome you all to day 3 of PHC Research Week, which has been jointly organized by the Alliance for Health Policy and Systems Research, together with the Special Program for Primary Healthcare at the World Health Organization. Next, please. So before we start off, some housekeeping notes. If you have a question for any of the panelists, please use the Q&A tab. You can avoid using the chat tab because that doesn't send the questions directly to the panelists. The Q&A will allow us to respond to your questions and ensure that we have taken note of them. The session will be recorded and the recording will be made available after the webinar concludes. We want the roundtable to be as interactive as possible. So we have set aside time for questions. So please do type in your questions into the Q&A at any point in time. You don't have to wait for the designated time. Next, please. So this is an outline of today's session. We have an exciting lineup of speakers and panelists for you. And today's focus is on the future of PHC research, from research to policy action. Next, please. To give us a little context for today's conversations, this is the 3rd day of PHC Research Week. The first day launched the theme issue of the WHO Bulletin on Primary Healthcare. The second day explored the diverse findings from research that's been undertaken on primary healthcare as part of different initiatives by WHO and its partners. And today we'll be taking the next step and engaging with the critical question around bringing research to policy and action. We'll explore a range of issues and challenges, from gaps in the generation of contextualized knowledge and in capacity for research, and how best to develop locally acceptable solutions to accelerate policy action. Additionally, the conversations today will also build on our consultations earlier this year, in July 2020, on embedded research priorities for primary healthcare in the context of COVID-19. These consultations focused on the Southeast Asian and Western Pacific regions and were undertaken in partnership with UNICEF and the United Nations University Institute of Global Health. Next, please. So to give a little background on those consultations that I just mentioned, these were a series of multi-partner consultations. They launched a new initiative led by our chief scientist, Dr. Soumya Swaminathan. And the focus of the embedded research topic is that, of course, there is a need for more robust and relevant research on PHC, as we would all agree, but also that the research needs to be more responsive to local context and demands and priorities of decision makers in the health system, and to promote learning in health systems. So we started with 2 consultations with policymakers from more than 20 countries in the Western Pacific and Southeast Asian regions to understand their priorities on primary healthcare research. And we followed that up with a synthesis consultation, bringing together those participants with a group of funders and civil society organizations with a view to chart the next steps. Next, please. The key takeaways from the consultations were as follows. The participants were agreed that advancing PHC needs the support of a robust agenda of learning through health policy and systems research and implementation research. There was an acknowledged need for learning health systems, which is typified by the current COVID-19 epidemic, where the ability of country health systems to learn from both current as well as past experiences and from each other has been crucial to the success or failure of their response. And there was a shared commitment among all those present to embedded research into efforts to improve primary healthcare. And embedded research is defined as research carried out as an integrated and systematic part of decision-making and implementation. So we hope that today's discussions will build on the points from those consultations. And that's also a great way for us to welcome our first speaker who was present in that consultation and also is a welcome speaker today. For the opening remarks, we're delighted to have with us Ms. Anuradha Gupta, Deputy CEO of Gavi, the Vaccine Alliance. Since joining Gavi in 2015, Dr. Gupta has led efforts to put gender and equity at the center of Gavi's programmatic planning and to tailor support to countries within Gavi's strategy. Prior to Gavi, Dr. Gupta served as Mission Director of the National Health Mission of India, where she ran the largest and possibly the most complex public health program in the world with an annual budget of $3.5 billion. She's a passionate and influential advocate of women, young girls, and children. And she was named one of 300 women leaders in global health by the Graduate Institute of Development Studies. We all know her as the Deputy CEO of Gavi, but also as a steadfast supporter of primary healthcare, a believer in local knowledge and local capacity, and someone who has never hesitated to champion health equity and the needs of the most vulnerable. And before she came to Gavi in India, and when we were both in India, I knew her as a senior leader and decision maker in the Ministry of Health, and somebody who didn't just give lip service to research, but actually made the bold decisions to support domestically funded, domestically driven health systems research to support the National Health Mission. Ms. Gupta, it's a pleasure and privilege to have you with us. Over to you for your talk, From Research to Action, Health Policy and Systems Research to Advance Primary Healthcare.
We understand many of these deprivations are because of structural systemic causes, but we also know that there are several things that we can do to support countries which can actually help them overcome many of these barriers very, very successfully. And that is where the role of learning becomes so critically important. And that is where I am personally a very big supporter of the work that Alliance for Health Policy and Systems Research is doing, and the shift that you are trying to make in terms of your own thinking and action plan. We have collaborated very well with you and UNICEF on what we used to call decision makers-led implementation research. So last 5 years have been very exciting for our partnership, where we have seen that we have been able to build some sort of capacity for implementation research in 12 countries. And in several cases, we had some very exciting evidence and learnings coming out of the work that has happened, which will go a long way in informing both the policy and the program design in these countries. Just one point that I would want to reflect on is that in the past, we have been very focused on findings which are important from global perspective. And I do think it is time for us to make a very profound shift, understand that as we move more and more in the direction of highly contextualized, tailored strategies that are targeted towards those communities which are really the most marginalized and vulnerable, we need to bring a local flavor to the questions that inform implementation research so that the policymakers and the program managers get genuinely interested in those questions, finding answers to those questions. And once some evidence is generated, then they become true users of that learning. So really establishing that interest at the local level is going to be a key underpinning of all these efforts, which we hope to continue with you all. And this is not to say that a lot of this evidence that we hope to be able to generate and use at the country level would, of course, inform the policy setting at the global level. At Gavi, we are increasingly trying to gather learnings from the field and then step back and say how our policies should actually evolve to meet the needs of the rapidly changing context in some cases. For example, we have been trying to segment our support model in countries, and we realized that in those 10 countries that we prioritized as our first tier countries, we call them tier 1 countries, 10 largest countries in Gavi portfolio that accounted for 70% of under-immunized children when we embarked on our new strategy in 2015, and with high-level strategic engagement with political leadership in those 10 countries and amplified technical assistance, we actually were able to move the needle on equity in immunization and achieve a reduction of 22% in the number of zero-dose children, which is a remarkable achievement considering the fact that the number of zero-dose children in non-Gavi countries has actually increased by about 30%. So at a time when health inequities are getting compounded across the world, achieving a reduction of 22% in these countries is really a very, very strong indication of the fact that if we get our act together, we can bring a new momentum in these countries. But where we continue to struggle and did not achieve the results that we were hoping to achieve was in those 10 countries that are our tier 2 countries, which are fragile countries. These include Somalia, Chad, CAR, Haiti, Yemen, some of those countries that are facing active conflict besides a lot of other fragility-related phenomena. And these are countries which suffer from very high, not suffer from actually, which have very high fertility rates, but also where communities suffer from multiple deprivations. And it is these countries where, though we have sort of been able to push progress somewhat, these countries have struggled to stay ahead of the birth rates or the population growth. So really a very rich set of learnings coming from countries, reminding us that what works in Somalia does not necessarily work in Chad, or what works in Chad may not necessarily work in Yemen. And therefore the importance of highly, highly contextualized implementation research, as you said, Kabir, is something that we would be very, very supportive of. So I think here the key is going to be how do we get the policymakers really excited about this whole opportunity of new learning and the fact that these learnings are pragmatic, and can actually be practically used by them in order to understand some of the gaps, that exist, and also some of the new approaches that can be embarked upon in order to bring about improvements. And I think if we can get them excited, then we would have achieved a lot. At Gavi, we are going to focus a lot on learning now in the next 5 years, because as I said, leaving no one behind with immunization is a central aspiration. We know reaching zero-dose children is not going to be easy. Before we reach them, we've got to identify where these children are, but more than their geographical location, it is going to be very important for us to understand who these children are. What are their profiles? Why are they missed? What are the barriers that they face? And, some of the work that we have done has indeed, brought home to us the point that it is going to be an extremely daunting undertaking, because we know that there are several prejudices, several stereotypes, several social cultural norms, that we have to reckon with. So really, overall, extremely supportive. We know that at this point, countries do not ask for financing, for implementation research, and that is something we are trying to build into our guidance now, to actually encourage program managers and policymakers to start sort of thinking about the value and importance of implementation research, so that they set apart funding, but they also get excited about trying to agree on the right questions that will help them sort of inform their policy or their program design, as I said. So this is, of course, our investments are going to be multifaceted and multidimensional, but embedded implementation research is something that we would definitely prioritize. And as I said, one of the things that we are extremely focused on now is really bringing a primary healthcare lens to immunization. We know that immunization in many settings is the first and the fastest service to reach communities, and therefore can act actually as a foundation to other essential healthcare services. And so definitely we want to do that. But as I said, we also know that these communities that are being missed currently require not just immunization, but a host of other services. And therefore, our effort now is to work with other financiers and investors such as GFF, Global Fund, World Bank, to make sure that all of us start to pull in the same direction and really place a lot of premium and value on resilient learning health systems with equity at the heart of all our efforts. So this is something that we would be extremely, extremely willing to work with you all on, and really hope that going forward, we are able to, as a coalition, contribute to strengthen primary health care with a view to making sure that nobody is left behind, and really make the marginalized populations and reaching them as a key measure of our success. Over to you.
Thank you, Ms. Gupta, for that sweeping presentation, in which in very short time, I think you covered a range of really important themes. And I think the one that struck me the most, I mean, there were many important themes there, but was the shift of Gavi towards a focus on learning. And that research is only really relevant when it enables and contributes to learning. So that's really very much in line with our thinking as well at the Alliance and at WHO. But also important that you highlighted for us the importance of extreme poverty and how that exacerbates health inequalities, the fragility and the precariousness that has come with the COVID epidemic that has influenced the lives of these people, and that we may need to really rethink some of our strategies to target much more specifically at them. But also sharing your optimism, as you said, your diehard optimism. And I think the path to that is really to move forward this agenda on learning and to generate the evidence that is really meaningful to the users of the evidence. So thank you once again for these very wide words and also for your expressions of support. We really look forward to continuing our efforts, our collective efforts to advance this agenda of PHC, especially for the most vulnerable. And of course, exciting direction that you mentioned that, in future, if we see a world in which program managers are the ones, the decision makers in the health systems are the ones who really start to engage in research and ultimately to demand evidence, then that will really be a major step that we will have achieved, so that we are not always just producing research in the ether and trying to convert people to our points of view, but actually responding to demands and priorities that will help people to learn and make the right decisions to advance PHC. So once again, ma'am, thank you again for your wise words and for joining us today. I know that you have a very busy schedule, so we really appreciate your support and your encouragement. Thank you, ma'am.
Thank you.
So with that, we'll now turn to the next segment of today's proceedings. And we have another exciting lineup of speakers. I'll introduce all of them one by one. This is a roundtable discussion, so we won't be having individual presentations, but we will have a series of questions which we will pose to the speakers. So we are Delighted and honored to have with us Professor Malavika Sarkar. She is Associate Dean and Professor and Director of the Center of Excellence on Science of Implementation and Scale-Up at Brack University James Grant School of Public Health. She's a physician with a master's degree in public health from Harvard and a doctorate in public health from the University of Heidelberg. She's the founding director of the Center of Excellence on Implementation Science and Scale-Up, and responsible for research and capacity building on implementation research. Welcome, Malavika. We also have Ogo Chukwujekwu. Dr. Chukwujekwu is a technical officer in health system strengthening in the Western Pacific region office of WHO, based in Manila, Philippines. She works with the health policy and service design team in the division of health systems and services. And prior to joining Wipro, she worked as a health economist in Nigeria and as a health policy and planning specialist in the WHO regional office for Africa. She has a medical degree and a postgraduate degree in health systems and services research. We also have with us Dr. Alaka Singh, who is the unit head of primary healthcare in the Department of Health Systems Development in the Southeast Asian Regional Office of WHO. Alaka is an economist by training. She has a career in health and development spanning 2 decades, starting with the World Bank H&P unit in New Delhi and Washington offices before joining WHO. With WHO, she has worked on health systems at all 3 levels, including the Myanmar and Indonesia country offices. And as I mentioned, she's currently leading the primary healthcare unit at the Southeast Asian region office of WHO. And finally, we have our own Shannon Barkley, technical officer at the special program on newly established special program on primary healthcare at WHO. Not so newly anymore, it's now well established. Dr. Barkley is a technical officer for primary healthcare services in the evidence and innovation unit of the special program. She completed her MD at the University of Pennsylvania School of Medicine and an MPH with an emphasis in international health at Johns Hopkins Bloomberg School of Public Health, followed by specialization in family medicine and additional specialization in advanced hospital medicine. Her current work supports the implementation of the operational framework for primary healthcare. And throughout her career, she's been involved with the development of effective primary healthcare among underserved communities globally through direct service provision, health workforce education, health system strengthening, and health policy monitoring and evaluation. I request all the panelists to have their videos on. You can keep your mics muted for now, but please put your videos on so that we can see you. Welcome, panelists. Can I have the next slide, please, Jeff? We'll be posing 3 questions to the panelists and we'll ask them to respond to them one by one. We also invite the audience participants to look at these questions and see if they would like to frame specific comments or questions to the panelists based on these. So we will ask what actions need to be prioritized at country and global levels to close gaps in locally relevant knowledge to accelerate policy action. How can PHC research and researchers better help to advance the neglected PHC agendas in countries? And what needs to be done to address the need for more country capacity to undertake policy relevant research on PHC? Next slide, please, Jeff. Okay, I think we'll stay with the previous slide, so that's for the Q&A. So we will start with question 1, and I'll invite Dr. Malavika to start us off with 2 minutes of her thoughts on question 1. Dr. Malavika.
Thank you, Kabir. So I think before we kind of think about the actions, we need to understand there are 4 fundamental concerns about the primary healthcare across the world. One is that that primary healthcare still now is very much MNCH focused, which actually kind of prohibits to expansion of care because it's MNCH focused. Secondly, there's a disjointed relationship with the secondary and tertiary care. So there's no structured referral system. The third is there's an absence of health information system, which is required for a continuity of the care. And the finally is that the failure to coordinate or bring the existing other primary healthcare service provider, like informal provider, the drug outlets, the quack doctors. So depending on the country, these 4 problems actually varies. So before taking the action, I think it's very important, like, your second question is about the research, that what is the status of these 4, the problem, that the focused MNCH, disjointed secondary with the secondary tertiary care, absence of a very comprehensive information system, and the failure to coordination of the existing primary health care. And if we focus on those, I do think that is very important, then only we can think about collectively that what could be the action point, because I strongly believe what mind does not know, I cannot see, and what I cannot see, the improvement cannot be done. So I'll stop here.
Thank you, Malavika. So let's invite the other panelists as well, and then maybe we can have a round of questions if we have them. So why don't we have Ogo next? Ogo, please.
Thank you, Kabir, for having me. So I think just to confirm, we're still going ahead with the first question.
Yes, please. We'll go one by one with the 3 questions. So this question, again, to remind our audience, is what actions need to be prioritized at country and global levels to close gaps in locally relevant knowledge to accelerate policy action on PHC? So it would be great if you could speak to that.
Thank you, Kabir, and thank you again for inviting me for this session. So I think similar to what Malavika has said, and it was really very inspiring to hear Anuradha share some of the change in focus coming from Gavi. For me, the first thing I would really say is that before we can, the first action that needs to happen is to know what it is that is the locally relevant knowledge that for each context, right? And that in the consultations we've had, that in discussing with the countries, we've seen how the ongoing COVID pandemic has brought some of these to light in so many ways, but these were not issues that are new. They're just sharpened by COVID. They were existing, they were just ignored or neglected, and the outbreak simply highlighted them and brought them into sharper focus. And so that is one critical thing. And I think, like Anuradha had mentioned before, that we have, through the consultations, we've sort of brought a lot of these, looked at what's common, refined, prioritized, and that is useful for driving a broader regional or global learning agenda. But in addition to that, we still have to focus on what each country is needing, which will vary from country to country. If I look across the Western Pacific region, we have countries that are doing pretty well in terms of already trying to learn and do research that is translated from the OECD countries to the Pacific Island countries, many of which are really just trying to keep their heads above water. So that's one thing. That's understanding what these gaps are and what the real issues are. We'll need to go at country level, and in some countries actually below that level to subnational or local levels, to really know where the issues are and what it is that they need to understand. That's one. And then secondly, I think there's really need, and I know we'll get a bit more to that in later questions, but there is a need to support local institutions in being able to conduct these and answer these questions in terms of being able to do research or support research that will answer the questions that keep policymakers up at night. And for a long time, we often do research where someone comes externally to support the country. And of course, that's useful, but increasingly we will have to build more local capacity, because that's really the only way to keep this sustainable. And like Anuradha mentioned, at getting to the point as well where you can have even policymakers or district health managers themselves really thinking of questions that need answers and figuring out a way to get the answers to those questions, even where it's not what we would call a big rigorous research program, which and then doing this will also require that there are investments in supporting research in countries, both from governments, but also from external partners who are supporting countries in many ways. There's been a long history of trying to get fixed proportions of budgets towards research. I think that has not been very successful in many contexts, but I think that even without being obsessed with those percentages, whatever governments can put in their budgets or allowing flexibilities within their budgets for policymakers to be able to commission research that answers specific questions that they need would be useful. But even more than that, we know that so many countries, many of the lower middle income countries, the lower income countries are receiving donor funds, and being able to really include as part and parcel of a lot of the programs they are implementing at primary care level, some way to do and understand and embed research would be a very useful way. But that also requires that the partners who support countries or any external entity that is supporting countries would have to be willing to put the country's priorities ahead of their own institutional needs. It means that even if I'm sitting at a regional office and I have a question burning, I mean, we do feel a bit of that pressure to want to find out how is every country doing this particular thing. But whatever it is that I'm trying to answer may not be the question that some of the countries are really interested in at that point in time. And so we have to also be willing to put the country's needs first and support support their roadmaps and their plans and their priorities to be able to answer the questions that matter to them and not necessarily the questions that matter to us. And I think that's one way that we are trying to work with some of the countries now that are starting to take tentative steps in this direction. And as much as possible, we are trying to support that. Yeah, so those are some of the main things I'll raise for now, and happy to answer any questions later. Over.
Thank you, Ogo. You've raised a number of big issues, actually. I think you mentioned things that have already been mentioned before around local institutions and capacities, but also the real politic of actually putting the country's needs first, and you know, especially when it comes to external partners and the trade-offs that are associated with that. And also you mentioned the importance of going below the country level to subnational and more local contextual level. So thank you for those great points. I see there's already questions coming through, and we will have a round at the end of this in which we'll ask the panelists to respond to some of those questions. So just so that I'm not putting you on the spot, panelists, please do check the Q&A box. And if there's any particular questions you would like to answer, then you'll be most welcome to volunteer yourselves. Not yet though, I'll still want to invite responses from Alika and Shannon. And I'll also invite audience members to put in more questions if they wish, and just at any point in time, you don't have to wait for the Q&A session to do that. Alika, over to you for your interventions.
Thanks very much. Thanks very much for having me. I do think the three questions are quite interrelated. So let me focus on some particular issues regarding question one, and I certainly agree with the two panelists that came before me. So let me extend and let me add some additional issues there. For me, the operative phrase is really local relevant knowledge, which means really building up, bottom up, a perspective bottom up for practical and feasible policy decisions. And really at country level, we still have some ways to go to establish what we've been saying for a long time, a culture of knowledge-driven decision-making at all levels. To me, this still remains very relevant, and what really needs to be prioritized is perhaps giving what we've been talking about, a culture of evidence-based or knowledge-based decision-making, some sort of structure so that we can build the capacity to operationalize it for PHC. Now, I don't mean to be sounding very inside the box in my thinking, but structure is important here because both a culture of decision-making is difficult to define, and also because the issues around PHC are very contextual as well. So really it's double jeopardy when it comes to operationalizing research. Let me quickly suggest some attributes of this structure. One, it does need to be institutionalized. It needs to be institutionalized bottom up, and in a way that it supports buy-in at all levels by all stakeholders with respect to identifying research priorities, contribution to knowledge for policy, as well as the use of knowledge across all levels. Really, this last point, this link between knowledge and policy and decision-making is quite critical and must be clear and transparent. Also, this will lead to a demand, a domestic demand for research, for policy, rather than being fund-driven. And that leads me also to at what we can do at global level. It's really more support on conceptual issues, on research designs and interpretation for policy, knowledge and experience sharing, both on research as well as structures that have worked and why, particularly through partnerships. Sometimes we do have ourselves as partners supporting different research, different methodologies even for the same area of research. And if I may just give a case in point, we've been working a lot on costing delivery of COVID vaccine, and we have two tools, one from WHO and one from the World Bank. So I think there's a global responsibility beyond tools, but also in terms of collaboration on research. If I may very quickly give an example from Myanmar, where we were looking at what can be done in terms of interprofessional education, interprofessional development, and interprofessional collaboration for strengthening primary healthcare. Now, WHO provided the research design, and a local institute, a national institute, the Nursing University in Yangon led the research. It has credibility in terms of both technical standing as well as a research to policy entity. It had a bottom-up network of nurses that were involved in the research. So there was already buy-in being built up to implement the policy decisions as well. There have been very important findings with respect to existing policies as well as future needs. And the university is now mandated to follow up regularly to inform future policy dialogue, working with local academic institutions. WHO also provided a platform to exchange knowledge and experience sharing, particularly, for example, with Thailand, which is very advanced in this area. I've given an example of the kind of institutionalization that we need really to build that culture of knowledge, of research, of evidence for policy. Thank you.
Thank you, Alka. And I think very important to highlight that structure needs to underpin and undergird culture. Culture is very fuzzy and it's hard to, we do want to create those cultures, but we can't really measure them. But the structures is what is going to sustain and improve those cultures. So thank you so much for highlighting that and also giving those practical examples. Sharon, over to you for your response to the first question. I think our questions are overlapping, so which is great, as they should, but go for it.
Great, thank you. And it's always tricky to be last on such an illustrious panel. So thank you to my distinguished panelists for their excellent comments. Since we've had so much tangible on the ground knowledge of what's needed at country, I think I'll focus my comments on my role, which is largely at the global level. And at the global level, of course, what you sacrifice in nuance of understanding the context, not only at national level, but also at the critical subnational level, you gain in a bird's eye view of cross-country experiences and shared solutions to common problems. And I think that's where the global landscape has potentially some value add. And we can apply that knowledge in advocacy for PHC and PHC-oriented research activities like this, things like a WHO Bulletin theme issue and other theme issues that we've been a part of at other distinguished journals globally to raise the issue and importance and profile of primary healthcare research. In leadership, in continuing to keep this on the agenda, in mentioning it in global partnerships that we have with all of the excellent partners who are also part of this panel, but also throughout the research community partnerships that we have, the Alliance for Health Policy and Systems Research, of course, and then the partnerships that WHO hosts and helps co-chair, including the Accelerator on Primary Healthcare in the SDG Global Action Plan for Healthy Lives. And so placing research really at the center of those discussions and the key role that it has in enabling some of these global goods to be translated in terms of, applying that framework to understand the actual bottlenecks, actual challenges at country level. And to that end, I think our special program on PHC, which is where I work at WHO headquarters, has been very conscious of these avenues that we have to support countries in research and have tried to apply them systematically throughout our program of work. We have the newly adopted operational framework on primary healthcare, where primary healthcare research is a critical lever, one among 14 for improving primary healthcare globally. Is a compendium document to the operational framework. We are currently developing monitoring and measurement guidance. I think data is foundational to research. And so offering guidance on best practices globally for measuring and monitoring primary healthcare. This of course builds on work that we have been doing with the Primary Healthcare Performance Initiative and with other partners in this space for the past 5 years, but brings it together in line with the operational framework, which countries have just adopted. In addition, we have a series of case studies building on the excellent case study work that has been going on over the past few years, some of which has been presented here in this forum, but aligning those to the levers of the operational framework so that countries can see how other countries in perhaps their similar context have been able to make tangible progress, recognizing of course that that tangible progress will always need to be contextualized. And then also the role that we play in terms of knowledge synthesis, and drawing on that best available contextual knowledge to draw cross-cutting lessons and translate those into products that can be recontextualized, such as policy briefs, which we're planning to do. I think importantly, the global level also has a role to play in terms of technical backstopping and making available resources for this effort at national level. And so as part of the embedded research agenda that you've been discussing, which is already active in the Southeast Asia and Western Pacific regions of WHO, along in partnership with UNICEF and the UN University, we're looking at extending that to other countries that are receiving intensified support on primary healthcare through WHO and the SDG GAP partners. And to ensure that as we do that, that the output is not just a one-off research article that answers the policy question that was burning at that point, but that we're conscious in the ways that we provide that support to build toward this culture, as Alika said, of evidence-based policy making, and really encouraging the organic growth of the virtuous cycle between research, knowledge, policy, and evaluation through the combined effort of those global goods that we're producing. And hopefully the end result of all of that at country level is improved prioritization and verbalization of research priorities by ministries of health, some earmarked funding acknowledging all the challenges that OGO has raised for research through research institutions that are aligned to those global or to those national policymaking priorities. And then also incentives for people to pursue careers in primary healthcare and primary care, both as clinicians, clinician researchers, and also health systems researchers more broadly.
Shannon, you raised the important issue of how global institutions can contribute to this agenda, which is increasingly we are agreed should be driven locally and at country level. I think really crucial interventions there around the role of guidance and compendiums, and also highlighting the work that's already been done by the Special Program on Primary Healthcare and its predecessors, also in collaboration with the Alliance. So thank you very much for that. I think we're getting really rich inputs, but we also got a great set of questions up on the chat box. So in the Q&A box, and I have my eye on the clock. So I think what we should do is we might condense the next section and take both questions at once, but I think it's time now to take a look at some questions. If there are any volunteers from among the panel to answer any particular question, please just go for it. Otherwise, I can read some of them out, and we can invite questions that way. Please take no more than a minute to respond so that we can address as many questions as possible.
Kabir, I just want to actually, because I raised the concern, but not the action. I think So the two action I think is very important. I'm talking about the bottom up approach, but one is the capacity of the policymakers and the implementers about the implementation research. Because if they are not aware, they can't prioritize. So that number one, it's not about the capacity of the researcher or infrastructure. The second is that whether can we actually integrate implementation, embedded implementation research as a part of the monitoring framework. Then it will be an ongoing kind of a task. So these are the two action I think is very important to kind of go to the next step. Yeah.
Thank you, Malavika. So I'm happy to read out a couple of questions, but if one of the panelists is ready with a response, please just raise your hand, or else I can read out the first question. So how can we build data literacy at the community level, considering that many community health workers and their service users have limited literacy in local and national languages? That's a very interesting question that comes from Abimbola Olaniran. So that's one question. I'll read out another as well, and then let's see if the panelist wants to respond.
I would like to answer to that actually, data literacy, because I do believe that it's possible, because given that experience in Bangladesh and BRAC, that actually it's possible to train the community health worker with the local language who can use the smartphone and tablet. But the two things is very, very important if you want to continue that. One is rigorous training, refresher training. Often we forget about the refresher training and the structured monitoring. And there are a lot of success stories now. So I personally believe that it's possible to create a data literacy at the community level and with the local language. Thanks.
Thank you, Malavika. Clearly speaking from your rich experience. So thank you for that. And I'm sure you can provide more information to us. And if there are any links you'd like to drop into the chat box, then they'll be visible to everybody on your experiences with building literacy in different languages. Second question is, historically, PHC seems to work better in rural settings. What do you think are the issues to be addressed to have its core principles work in urban environments? Another big picture question, and I think invite the panelists to respond. It's a great question. Thank you. That comes from Takugang Innocent, Professor of Public Health, University of Yaoundé.
Okay, again, Bangladesh experience. I think everybody knows the Bangladesh that, like, in urban area, there is no primary health care. It's not the Ministry of Health. It's actually under local government, Bangladesh, completely different structure. So what can happen in urban area to bring a primary health care, what Bangladesh has done, offered by the NGOs or international NGOs, but you can also bring the general practitioners on board. So that's what I said in the beginning, that we need to think about other primary healthcare service providers. So in urban setting, it's very difficult to introduce a very new structure, but bringing the kind of local non-government organization, international non-government organization, faith-based organization who provide primary healthcare, and all general practitioners, the provider, if you can coordinate that and facilitate it, then it's possible to have an effective and efficient primary healthcare at the urban setting.
Thank you very much. Do we have any other panelists?
Yeah, could I add to those excellent comments? I think in general, one of the issues that we face in urban settings is the multiplicity of types of providers throughout the health system and at all different levels, and the tendency for the perception to be that health services are delivered more effectively by subspecialty providers than by primary care providers. And so there tends to be leapfrogging. And so some of the critical elements that need to be in place is building both the technical and experiential quality of primary care. So investing in the patient and individual experience of primary care, making sure facilities are clean at primary care level, just like they would be if you went to a hospital, making sure they're attractive, making sure people are treated well when they enter the facility. As that are often the reasons why people seek care elsewhere, because they associate that experience of care with higher technical quality, even though we know that association doesn't always hold. Sometimes there's also lower technical quality in primary care, and that needs to be strengthened globally. I think in addition to those issues, once you have strong technical quality and a strong patient experience at primary care level, you need to institute gatekeeping it's one of the essential elements for primary care to be functioning well within a system, and that it needs to be connected strongly as the core of integrated health services to serve that hub role. It needs to have good communication capacity with networks of specialists and subspecialists and hospitals. And subspecialists and hospitals also need to be educated on the role of primary care once these elements are put in place, so that the communication flows well in both directions, so that subspecialists come to trust the care that primary care provides for their patients as well, and that they are also able to help build the capacity of primary care providers to serve that really critical role.
Thank you, Shannon. That was very insightful, and I think really highlights, underpins the need to rethink our urban health systems in ways that are also responsive to the primary healthcare agenda. And I think there's a fair amount of thinking about it, but not so much changes in the actual systems and structures. So it's a big agenda for growth, certainly. The next question is very interesting as well, and I'm going to target this specifically at our WHO regional office colleagues. So I'm going to ask Ogo and Alaka to respond, because they're really at the heart of this issue, which is quite political. How do you harmonize national and subnational needs with those of funders, especially when both conflict? Particularly low-income countries may not be able to fund their priorities and are forced to accept the priorities of funders. Ogo and Alka, over to you. I'm sorry to put you on the spot, but I think you can answer this easily.
Thank you, Kabir. We will do our best. So yes, I mean, I think I alluded to that, and it's a challenge that remains. I think that one part of it, of course, from Shannon's excellent points earlier, is advocacy that continues from various stakeholders and from governments to raise this issue. And we are seeing in a few contexts, of course, that changing a little bit, because we know that at the initial phases, especially for some of the programs that were heavily donor funded, there was a drive to do specific types of research around it. But I think when you also realize that the health outcomes get to a point where it no longer, you sort of plateau unless you begin to solve the specific problems that for that context. And we're seeing a bit more of that flexibility. Maybe we still have a ways to go there, but I think this has to, we have to continue to advocate on behalf of countries that do rely on external funding to drive their health programs as well as their research programs, to be able to come to this consensus to put, like I said before, it's really that willingness to put the country needs to know that being able to get the outcomes that we want will come from doing research that solves the specific problems of that area. If I simply take a question that is relevant to Mongolia and try to apply it in Vietnam, I will not get a good outcome. I may get a good research paper, but at the end of my program, it's about what legacy do I leave behind. And that's why I'm very happy as well that we are having some donors like Gavi saying, yes, they are willing to support this learning agenda, and we'll have to continue to advocate for it, while also, of course, advocating that countries themselves are starting to put some of this, But on the other hand, too, some of it comes from, I will borrow as well from Alaka's points about the demand from policymakers in country. Because of the fragmented nature, sometimes people just want to implement their program and get their funding. They're not really concerned about the research or doing research that really helps them do better. And so if we're able to create a culture and a structure that really starts to build that demand from policymakers, we find that they come to the negotiating table with their donors a bit better prepared and better able to discuss and put forward their own priorities and try to make a case and a good rationale for it, which is one thing that they're not always able to do. For some that already know, they're not able to advocate for it or negotiate or make the case for it appropriately, and then they have to accept whatever is given to them. But we have also seen cases where some countries have been very successful in getting funding to support what they want to do. And I think if we can scale that and replicate that in more countries with the capacity for that, that would be awesome. Over.
Thank you so much, Ogo, and I think you speak again from experience while outlining some of those excellent examples. Alika, over to you.
Thank you, and I'm glad my colleague went first because she's answered the question quite comprehensively. Let me add from our region, quite frankly, we don't have necessarily a conflict. Certainly research may be underfunded in some of our countries, but I wouldn't go so far as to say conflict. Yes, the research priorities may be donor driven, but let me flip the question, flip the response a little bit and say that there is still the opportunity to use that funding, even though it may be focused on funder priorities to build capacity, because our national institutions are involved. So we can build the capacity. And the other thing is that we need, from WHO, for example, support the countries to take advantage of what funding there is to build that capacity, and not to consider the funding sort of one-off. The research is done, the paper is complete, the report is complete, and that's it. But really to take the opportunity to build capacity. Again, in our countries, in the region, I've really not come across necessarily conflict. There may be underfunding of other areas where the experience can allow both capacity building and potential to increase funding for other areas that may be relevant. Thanks.
Thank you, Alika, for highlighting the nuance in that question. And I agree that it's not always about conflict and confrontation, but sometimes about a misalignment. And also, of course, underpinned by the underfunding of research in general, which is something that we would all like to address. So I have my eye on the clock, and I really do see this as a really rich discussion, but we do need to move ahead as well. And I'd like to give enough time to our closing speakers. So I'm going to request the panelists to give their next response succinctly in 2 minutes each, if that's okay. And to pick one of the questions that they'd like to address, one of the next two. Jeff, if you could go back to the slide with the questions, I'll just read those out. And then panelists are welcome to respond to one of them, and I'll go again in sequence. I think some of it has partly been addressed. So how can research and researchers address the issue of the neglect of the PHC agenda in countries? It's a broader issue, but can research and researchers really contribute to addressing this sort of imbalance between primary care on the one hand, primary health care on the one hand, and much more clinical and hospital-oriented services that tend to be politically preferred and tend to dominate private markets, certainly in very low and middle-income countries. And the second question on capacity, what more needs to be done to address the need for country capacity to undertake policy-relevant research on PHC? So let's start with Malavika. Over to you, Malavika. One question.
Definitely, I think the second one, that PHC research can help advance the neglected PHC agenda. And it's not only identifying that what are the implementation bottlenecks about the drivers, but also what could be an efficient and effective implementation strategy. Most often, actually, we engages in randomized control trial that whether intervention works or not. We don't use a robust methodological design to see the implementation strategy, that how the PHC has been delivered, and what are the constraints. So definitely, I do think that PHC research, it can help advance. But going back to the first comment, that we have to focus locally all those 4 areas, that what is the gap in PHC that we can improve, and what needs to be done to address. One thing I think is very important, it also came as a question, about the implementers are not interested in our policymakers that implemented research, but we really need to kind of spread the implementation research literacy. I don't want to say that training, but literacy. And from my own experience, I have done several implementation research for UNICEF, and when we presented that, then BRAC came, and the UNFP also asked us to do some implementation research. So that implementation, understanding the importance, and to be fair with the policymakers and implementers, that most often we do the research and have this advanced analysis, complicated graph, and then publish paper. So to make them understand that how important that is and how useful that is. And another thing I want to bring here, that not only the research, as an implementation researcher or embedded implementation researcher, we need to also learn the knowledge translation. How can we actually translate that knowledge so that it will be easily kind of an understandable for the policymakers and implementers, so that they can take action in the next step, not a very complicated policy brief or a paper or 80 pages report. So I'll stop here, yeah.
Thank you. No, very relevant practical advice. Thank you, Malika. Ogo, you're next. You can choose any question.
Thank you.
To answer.
Yeah, thank you, Kabir. Malvika has spoken so well on the second one. I'll just touch a little bit on the last one. I think most of us have already touched on this a bit more, the need for more country capacity. But I think for me, it's that really the best way to learn is to do. And so building country capacity will really require us to provide more opportunities for in-country institutions, whether national, whether local, and different types of institutions. I see a comment from a question as well from someone in the chat, which I'm trying to roll into this, that working with local institutions to conduct research does not have to be just the universities or those that are already well known, because you have to build wide-ranging capacity from different disciplines, and the greater the number of in-country institutions that we can use, the better. In working with countries to try to do work around community engagement, we've seen how donors go through and say, oh, we can't use any because none of them have the right capacity, so we're going to bring the international NGO to do this. But I think we have to start to work with them. Some other programs have tried different approaches like twinning institutions, and that's maybe something that we can try in research to see how to partner local institutions with external ones, but have an explicit way of and an explicit roadmap really to transfer capacity and let them take over. And we are trying to look at that for new requests that come through from countries. We will be trying to work with them to see that they are put in the role that they can, through doing, learn this, but also that researchers and research institutions will also pivot and begin to learn more depending on the demand. And so it comes back to that issue of where there is more local demand, you're likely to find more in-country institutions starting to gain that capacity and to be eager to learn where there are opportunities for it, and understanding how to do this. I think it's really been remarkable how during this outbreak again, we've seen how even those who have never always really used turn to evidence for things, always ask questions. They say, oh, do you know what is the best evidence? Is there any evidence for this intervention? Is there any evidence for that? And they're wanting to know what has worked, not just something pulled out of the air. And I think if we can adapt or find a way to sustain that demand and that momentum going, even when we are coming out of this outbreak, that our health systems and the PHC approach will be better for it. So those are my main points. Over. Thank you.
Thank you, Ugo. Alaka, over to you.
Yeah, thanks very much. If I may actually go back to question 2 and build on a little bit on what Professor Malvika said, just in terms of perhaps a practical approach of supporting PHC research and researchers to advance on the neglected PHC agenda in countries. I totally agree. If we look in this region, Southeast Asia region, PHC is mentioned pretty much in all country constitutions. But somehow we haven't got that kind of traction in spite of this high-level inclusion in our constitution. Now, at the core of PHC, and this was said by our keynote speaker as well, is really service delivery. And one way perhaps to help PHC research would be actually to join forces with established programs to highlight the significance of PHC for them. So really making an effort to embed PHC research across programs and perhaps even health systems areas. This would mean, indeed, we're coming from different perspectives, but we are all moving towards the core of primary healthcare, really to create an entry point for ourselves. And again, let me give you an example. For example, in Sri Lanka, what we're trying in the region, Sri Lanka is now very interested in looking at non-communicable diseases and a way to really include NCDs at primary level of care. So we, in a way, in the PHC unit are piggybacking with the NCD program to try and look at the possibility of embedded research for PHC through their NCD intervention in Sri Lanka. The other thing with PHC is also that it's contextual. So we also need to look beyond health at social and economic determinants. And here again, trying to find that entry point, for example, with other health systems areas, including health financing, to embed the concept of PHC and the concept of embedded research for PHC might really be useful. Of course, the type of research will depend on the context of the program and the systems area, whether it's embedded or different types of research, and we can certainly provide the technical backup for that. But I really feel that one way of perhaps supporting the PHC research is, and also to getting that buy-in across programs and health systems, would be try and embed this in their efforts at country level. Thank you.
Thank you, Alka. Again, very clear and very practical points, speaking from experience, and also your endorsement of the embedded approach, which is clearly resonating across many of our panelists. Shannon, over to you for the final intervention, and then we'll move on to our closing remarks.
Thanks very much, Kabir, and thanks, colleagues. I'm also going to answer number 2, though by equity I should shoot for number 3, but number 2 caught my interest. So I think that in general, the PHC agenda in countries is neglected for a lot of reasons. Vertical programs or hospital centrism exists for a lot of reasons. It's visible, it's politically expedient, it tends to move faster. There is demand from the population, and there is a huge amount of job creation that happens around both of those agendas. And so I think one of the critical elements that's needed at country level from PHC research and PHC researchers is bringing to light contextual knowledge that drives demand from citizens for primary care, and that be shared not only in peer-reviewed journals, but that it be shared in public fora and translated in ways that reach people, so that as they vote for leaders, they're voting for leaders that are recognizing the role that primary care plays in keeping its and primary healthcare more broadly play in keeping populations healthy and helping them when they're ill. I think it's also really important to demonstrate the evidence for PHC as equitable, efficient, effective in your particular context, and to build further research agendas around topics that you know respond to policymakers' needs. If they are trying to push a policy on finance, work with your financing colleagues, get some financing researchers to generate the kind of data that they need. And this goes to my next point around building coalitions. So don't just build research topics that are policy responsive, but build coalitions. PHC is a huge field, and it requires multidisciplinary approaches in research, just like it requires multidisciplinary approaches to providing primary care. And so acknowledging data from policy, or acknowledging data on policies that keep people healthy in multisectoral ways, acknowledging data on health systems research, as well as acknowledging the clinical data from disease-specific areas, while presenting that in a way and tweaking that in a way that demands that they be taken into account in a more comprehensive perspective, and how those are applied in ways that provide comprehensive care for people. Of course, we know that research on a single NCD is not always applicable when applied to a real patient sitting in a room with multimorbidity in both communicable and non-communicable conditions. And so, recognizing the complexity of people is primary care's specialty. And so acknowledging the excellent work that's being done by colleagues in vertical areas while tweaking that to have a people-centered lens, and also applying that in participatory ways that bring communities not only into the prioritization of research topics, but also into the planning and actual research process. And then lastly, I'll say that, primary healthcare and primary healthcare reform, we see in many countries is a 1 to 2 decade agenda that doesn't usually fit the political cycles of elected politicians or appointed ministers. They have a much shorter arc. And so I think when our politicians and when our ministers do something that is strong and that is of an advantage for PHC, I think it behooves our researchers to also play a role in bringing that to light so that that can be celebrated by people as much as the cutting of a ribbon at a hospital.
Thank you, Shannon, and thank you all panelists. It seems like time is really short for this conversation. We could go on, I think, for another hour and try and cover all these issues, and we would still be short. But I think a number of really important points have arisen. I mean, I think on the one side, there's a number of very practical and hard-headed concerns around the actions that need to be prioritized, local capacity clearly being one big one. The importance of reorienting the way we do research to respond more to demand. And as Alaka mentioned and others have endorsed, the importance of structures for evidence through the chain and for evidence use throughout the chain and not just at the point of use of evidence. And then also on the other side, the sort of realpolitik and the softer side of things, where it's really important to think about how to reconcile external and local demand and need. And also how to get buy-in for research at every level. And often there's a sort of a conflict, sort of a meso or micro level conflict between the research agenda and the action agenda at program level, and that needs to be resolved. They should be seen as synergistic. Again, also very excellent questions that came up, and I just want to acknowledge the questions that haven't been answered. I see N. Ravi, Faraz Khalid, Robert Skepier, and Shahid Iqbal, and a number of really interesting questions which I wish we could have addressed, but unfortunately for lack of time, we haven't. But we did get into issues of how urban health structures should respond better to PHC, the issue of language literacy, addressing PHC at community level. And ultimately, I think the big takeaway is, again, an endorsement of the approach of co-production and being more demand-driven, but also focusing on local context, on communities, and responding to the needs of local actors and local communities and local contexts better. So wonderful, thanks. I wish we could give you an ovation, but let's give you a virtual ovation. And thank you very much to this panel for joining us today. And we'll now move on to the final segment. So thank you again, panelists.
Thank you all.
So it's my distinct pleasure now to introduce the director of the WHO Special Program on Primary Healthcare, Dr. Suraya Dalil. Dr. Dalil, before her recent role as director of this program, spent most of her years providing health services to refugees across Afghanistan, Somalia, and beyond, by working with Médecins Sans Frontières, the International Organization for Migration, and UNICEF, where she focused on maternal and child health. She's also acknowledged for her contributions to one of the most relevant public health studies in Afghanistan's recent history that has greatly influenced policy decisions on maternal health for years. Dr. Dalil also served as Minister for Public Health in Afghanistan. Dr. Dalil, it's a privilege and honor to have you give our closing remarks and to close out PHC Research Day. Over to you, ma'am.
Yes, thank you very much, Kabir. Greetings to all of you. Can you hear me?
Yes.
Yes,
hello. Perfect. So it's a great pleasure to join you. I would like, first of all, to thank all the colleagues who participated in the last 3 days, part of the PHC Research Week, the Science Division of WHO, the Alliance for Health Policy and System Research, as well as colleagues from regional offices, country offices, experts, and friends around the world. So back to you, Kabir. Do you have questions, or I just go ahead with the remarks?
Please go ahead with your remarks, Dr. Dalil.
Okay. First of all, the special program on primary health care is a new program established in WHO Geneva, and the program is established based on the Director General vision to embrace equity and human rights, solidarity and social justice, and to renew the global commitment made in Declaration of Astana and in the Global Conference on Primary Health Care in Astana in October 2018, and following the 2019 political declaration on universal health coverage. My takes from the last 3 days has been, first of all, with regards to the primary health care, the approach. I have been following the discussion yesterday and the first day, and I'm very glad to hear talk from colleagues from countries, especially from Ghana and from Nepal, who emphasized on comprehensive primary health care approach, and also speakers earlier this afternoon who stressed on the need to go beyond maternal and child health and look at primary health care from a comprehensive approach. That means the equity-based and people-centered that are core to the primary healthcare approach as part of the agenda. In fact, this was also very much highlighted last week in the World Health Assembly, in the resumed session of the Assembly, where a number of states highlighted their willingness, their commitment, as well as their policy actions for comprehensive primary health care at the national and subnational level. I'm also very glad to see the theme on community engagement and community empowerment came very strongly throughout the last 3 days. The healthcare decision making at the community level and their role in decision making beyond being recipient of healthcare and being part of the demand for accountability and decision making has been highlighted in a very profound way. Integration of primary care with public health functions, especially essential public health functions and population-based services is critical. And I have noted that that has also been reminded throughout the research week. Very importantly, we have been learning that PHC closely links with resilience and potentially with building better health systems. So with regards to the context-specific and context-focused PHC research, I'm also glad to say that part of the development of the program of work for the special program for primary health care in WHO headquarters, we had a discussion with all 6 regional offices of WHO. And in all of them, the message came to us that you make primary health care context specific. It's very much context specific, and in every context, it evolves over the number of years. And it has been evolved in the last 4 decades, and it's evolving. So I'm also very glad to see that that context specificity also came in this discussion in the research agenda. And especially that it has to be bottom up, and it has to, the research and our embedded research agenda should be able to capture local solutions and local innovations. The issue about, and I would like to stress on the fact that health systems that do not learn, they do repeat mistakes. And it's like human being. If we do not learn, and if we do not continuously learn, we do mistakes, and we repeat mistakes, and that's very critical for us to build systems that learn and able to integrate that learning into their actions and decisions in a sustainable and systematic way. With regards to the program itself, I go back to the program, to the special program. And what is special this time for the program is that it's not a vertical program. The program is going to leverage on the technical expertise and technical capacities that exist across the WHO. The program is very much amplifying the very principle of primary health care, which is coming from the Declaration of Almaty, and that's the equity and human rights as being the core of primary health care, and looking into not only diseases, but also the health and well-being aspect of care. We have got a principle-based approach where PHC is the backbone for universal health coverage, for SDGs, and for health security agenda. Last week, the World Health Assembly adopted the operational framework on primary health care, and our role is to support member states through our regional offices and country offices and the implementation of the PHC operational framework. I'm very glad to see that the measurement, the data, and the evidence was strongly amplified in this week's discussion. And I'm coming from a government background. I worked with my government for the last 10 years, and I know in order for the policymakers to make tough decisions, they need to have convincing evidences and data to show that this is the game changer and this is what matters for people, for the constituencies. We can only do that through data, through evidence, and through research. So the new era for primary health care is very much based upon evidence and research and innovation, and the research and innovation is part of the program, as earlier mentioned by my colleague Shannon Barkley. In this program, we are also have the mandate to keep the PHC renewal in the agenda. PHC has been renewed 2 years ago, but keeping that momentum, building on that momentum, building on the political commitment that leaders and global health leaders and country leaders and global figures made on primary health care, and translate that vision into action for people who are left behind, for people who live at the very hard and difficult places in the world today, and also people who live in places which are probably easy to reach, but they are ignored for a number of reasons based on driving inequalities and inequities in those societies. I would also like to touch base on the questions that was raised by one of the participants earlier about the urban settings and primary health care being relevant in urban settings, and I say, yes, that is. My colleagues mentioned about primary care and that the provision of service delivery in an urban environment, but beyond that, it's the primary healthcare approach acknowledges the role of people, the role of communities and the multi-sectorality of health. And that's very important in the context of urban planning with regards to broader role of people in building urban environment, in cities that are pro-poor, and we do not have cities that separate segments of population based on their income or economic profile, and having more integrated and holistic urban settings. Also factors related to road safety, water and sanitation, and eventually toward green cities and people-friendly, communities-friendly urban development. I would also like to say that primary healthcare approach is not only relevant for low-income countries, but it's also very much relevant for high-income countries and OECDs. I know that in one of the panels in the previous days, the OECD report on primary healthcare was discussed, and I just want to make two references into that one, that avoidable hospitalization costs in 2016 in 30 OECD countries was $21.1 billion. And that 1 in 4 persons with chronic conditions did not receive any preventive care in the last 12 months in the EU countries. So the primary healthcare agenda is not only relevant for LMIC, but it's also relevant for all of us. And we have seen that repeatedly in the response to COVID-19 with regards to morbidity and mortality profile from COVID-19 or for comorbidities. So I would like to stop here. Back to you, Kabir.
Thank you, Dr. Dalil, for closing out the day and for those very clear and supportive words of encouragement for PHC research. As we all know, primary healthcare has been given particular and special status by the World Health Organization through the creation of the special program. And Dr. Tedros never fails to mention it in most of his public announcements that primary healthcare has a special place. And indeed for the Alliance as well, it's a very important partnership. And I'd like to thank Dr. Dalil for that, for the partnership that has led to this special PHC Research Week, but also for our other engagements and collaborations that we have been taking part of so far. So thank you, Dr. Dalil, for your support for this research agenda and for our PHC Research Week. It's been a privilege and honor to have you. So before we close, it's now my pleasure again to introduce Dr. Abdul Ghaffar. I'll be biased in my introduction since he is our director, the director of the Alliance for Health Policy and Systems Research. And I won't embarrass him with a long introduction, but let's say that we all know him as one of the drivers and the champions of health policy and systems research. And I know that he is also an ardent supporter of primary healthcare and primary healthcare research. And he is really the moving force behind this entire week of research that we have shared. Over to you, Dr. Ghaffar.
Thank you, Kabir. Excuse me, I know we have already 6 minutes late, so I just want to say few things before we close on behalf of Dr. Soumya Swaminathan, the chief scientist, because she is traveling, and on behalf of the Alliance. So as Kabir has said, and Suraya has said, DG takes a genuine pride and he believes into the primary health care, and he kickstarted the whole event by sending a opening message for this PHC Research Week. And he took a time to write an editorial into the WHO Bulletin. So he genuinely believes if we really want to achieve the USC, the only way is that we have stronger PHC systems. So the few statistics, I think we are delighted that over the last 3 days, we have around 400 people in total in a given time, sometime overlapping, 22 panelists, and a wealth of existing resources was shared, 2 special issues, a book by David Beshai and others, case studies from premises, and several other articles and resources. There has been a very strong engagement on the social media, including some like messages from the DCO, DGO, and all other leadership of the WHO. The one thing I would just like to say that the recording of all session is available on the Alliance website, along with the links to relevant resources for anybody who might be interested to share with other colleagues or just want to look at ourselves. It is our, in fact, a great delight that over the last 3 days, but especially today, there was a very high emphasis from Dr. Ms. Gupta to everybody else that we need to have more and more focus on the contextualized local knowledge, which we believe within Alliance and the WHO that is demand-driven embedded research. And I think that's the only way that ultimately we want to have, as Surya was saying, it is very context specific that we need to have the money for the implementation research, which should be embedded into the program. And that is what we want to do, that there's a learning is inbuilt, the research is inbuilt, evaluation is inbuilt. These are not afterthoughts. So it is not monitoring, it's not quality control, but as part of the implementation of the program. So as I said, we are already late. So I just want to say my most sincere thanks to all panelists today or before, to all participants from all over the world, but especially to our colleagues from the regional offices who has participated, supported the consultation, especially in Wipro and CRO, but most particularly to our colleagues in the PHC special program, especially to Surya and Shannon Berkeley and others. So I think we are looking forward to further strengthen our relationship and collaboration so that we can move forward. And as Alka was saying, it is at the priority at the list of many countries. It is mentioned in the strategic plans and the documents, but we are still not able to realize it. And that's the push we have to make by generating the local knowledge and having the policy dialogue. So thank you again to everybody, and most important to my own team, Kabir, Aku, Robert, and Jeff. It would have not been possible without your hard work, not today. And in that regard, if I can include Shannon into my team, if Surya does not mind, over the last many weeks and months, they have all worked together to make it a success. So thank you, everybody, and have a good weekend and a good day. Over to you, Kabir.
Thank you, Ghaffar, and I'll leave the last word with you and thank everybody for participating. And see you soon, hopefully. Bye-bye.
Thank you.